Greetings, everyone. It's my pleasure to be with you today to discuss the cutoff value for 30-second CT scan test in myocardial infarction. Before we begin, I would like to provide some introductory information about potential conflict of interest associated with our study. This research has not received specific financial support, and the authors do not have any industry relationship related to this work. Feel free to ask any question throughout the presentation. Now, let's proceed with our study. Exercise tests are utilized to assess functional exercise capacity in cardiac disease, predict prognosis, interpret clinical research findings, and evaluate treatment responses. The tests used for this purpose include the cardiopulmonary exercise test, CPET, and 5 tests such as the increased speed shuttle walking test, 30-second sit stand test, and 6-minute walk test. While the CPET is considered the gold standard, there exists a debate in the literature regarding whether having experienced a myocardial infarction with the last month considered a contradiction for CPET. 5 tests are widely accepted and commonly used methods for assessing individuals with MI, the population under study. While the 6-minute walk test is considered the gold standard among 5 tests, its practical application in daily clinical settings can be challenging due to the specific environment and time requirements. As an alternative to 6-minute walk test, the 30-second sit-to-stand test proves valuable. This test is completed in a shorter time frame, eliminating the need for special environmental conditions and, most importantly, induce less fatigue in patients. This study aimed to determine a cutoff value for the 30-second sit-to-stand test that characterizes functional exercise capacity. 22 patients who had experienced MI were included in the study. For each patient, the 6-minute walk test and the 30-second sit-to-stand test were conducted on the same day, ensuring the necessary conditions for the test and allowing appropriate testing intervals between the tests. Patients who walked less than 450 meters in the 60-minute walk test categorized as having full exercise capacity, while those who covered for 150 meters or more were classified as having good exercise capacity. We utilized Ocaker analysis to understand how effectively the 30-second sit-to-stand test categorizes exercise capacity. Think of the ROC curve as a visual guide showing us how well the test balances sensitivity and specificity. The area under the curve, AUC, gives us an overall picture of the test performance. Bigger AUC values means the test is better at distinguishing results. Now the Yalden index comes into play to help us pinpoint the sweet spot, the optimal cutoff value that strikes the right balance between sensitivity and specificity. This type of analysis is pretty standard of guessing of accurate as test is within a specific group of individuals. We found that the optimal cutoff value for the 30-second sit-to-stand test was 12 repetitions. The area under the ROC curve was 0.77. Additionally, we observed a significant correlation between 6-minute walk test distance and the 30-second sit-to-stand test repetitions. In patients who have survived AMI, performing fewer than 12 repetitions in the 30-second sit-to-stand test indicates compromised functional exercise capacity. This cutoff value provides variable in pinpointing individuals who may benefit from targeted interventions to enhance their functional capacity. Thank you all for your attention and time today. Please feel free to contact us with any question or for further discussions. Best regards.